Welcome. Great that you're interested in our research about combining diffuse reflectance spectroscopy and ultrasound imaging for resection margin assessment during colorectal cancer surgery. My name is Freya Geldof and I'm a PhD student at the Department of Surgery in the Netherlands Cancer Institute. In the coming slides, I will show you the results of our Phantom study we started with and how we are continuing this approach in an ex vivo study. Colorectal cancer is one of the most common cancer types. Each year, 1.4 million patients are diagnosed with colorectal cancer worldwide. The main treatment of colorectal cancer is in most cases a surgical removal of the tumor, if necessary in combination with neoadjuvant chemo or radiotherapy. The aim of this surgery is to remove the entire tumor together with a margin of healthy tissue, while sparing surrounding healthy structures as much as possible. In the image on the right side of the slide, you can see the tumor in blue. The blue dashed line indicates the desired surgical cutting plane. However, identifying tumor tissue during surgery can be very challenging. Currently, in up to 20% of the cases, the tumor is not completely removed during surgery, which leads to increased risk of tumor recurrence and decreased survival rates. Therefore, it would be of great benefit to have a tissue discrimination tool that can provide real-time guidance to the surgeons. Diffuse reflectance spectroscopy, DRS, is an optical technique that has already been successfully used for tissue discrimination. In DRS, broadband light in the visual and near-infrared wavelength range is sent into the tissue using an optical fiber. In the tissue, the light undergoes multiple absorption and scattering events. The second receiving fiber captures the diffuse reflectant light, and the measured spectrum contains specific information about the tissue composition. However, so far this technique has mainly been used to assess the superficial tissue surface and homogeneous tissue volumes. To be able to evaluate resection margins up to multiple millimeters in depth, it's essential to also distinguish different tissue layers. In this study, we want to detect the tumor even when it's still beneath a layer of healthy tissue. When you look again at this image as showed before and we place a probe somewhere on the tissue surface, we would like to know that there is first a margin of healthy tissue of, for example, 2 millimeters, and beneath it there is a tumor. Therefore, we focus on two aspects: classifying the tissue types of the first and the second tissue layer, and also predicting the thickness of the first tissue layer. To facilitate this, we propose to combine diffuse reflectance spectroscopy with ultrasound imaging. Diffuse reflectance spectroscopy gives us information about the tissue composition, but there is a lack of structural information. Therefore, we expect it to be difficult to use this technique alone for more complex and inhomogeneous situations. Ultrasound imaging, on the other hand, can provide images of the tissue structure with a good resolution and more than sufficient sampling depth. In this new multimodal approach, we are combining the spectral information of DRS with the spatial information of ultrasound imaging to enable the analysis of more complex tissue structures and extract information from larger sampling depths. To examine the feasibility of this concept, we started with an animal tissue study. Two types of multi-layered animal tissue were used: muscle tissue with a top layer of fat and fat tissue with a top layer of muscle, and that one you can see in the current image. The top layer thickness of these tissue structures varied between 0 and 10 millimeters. Next, measurements were performed in a grid shape. At every location of the tissue structure, both a DRS measurement and an ultrasound measurement was performed. The DRS measurements were acquired using a broadband light source, a wavelength range of 400 to 1600 nanometers, and two fiber distances of 2 and 6 millimeters to retrieve information from multiple sampling depths. Ultrasound measurements were acquired using the Philips CX50 ultrasound system and a high-frequency hockey stick-shaped transducer. This flowchart shows the workflow of the data analysis. For the DRS spectra, two types of features were extracted and compared. For the ultrasound images, features were extracted based on the graph theory. Using the combined set of features in a regression analysis, the top layer thickness was predicted, and after that, the tissue types of both layers were classified using the extracted DRS features. In the next slides, I will explain these steps in more detail. Two types of features were extracted from the acquired DRS spectra: peak-based features and wavelet transform-based features. For the peak-based features, the dip peak height was calculated for 3 spectral regions with distinct peaks. 935 nanometers, that's the fat absorption peak. 985 nanometers, that's the water absorption peak. And then 1200 nanometers, that's the fat absorption peak again. The second feature extraction technique is based on the wavelet transform, which can be used to analyze spectra at different spectral scales. The input spectra were convolved with a SIMDAT low-pass filter to obtain approximation spectra. After that, the obtained spectra were downsampled by a factor of 2, and the procedure was repeated multiple iterations. The approximation spectra of the 6th iteration consisted of 25 features were used for the analysis. The ultrasound images were analyzed based on the graph theory, in which an image is represented as a graph. This is visualized in the image in the top right corner. The nodes represent the individual pixels, and the edges represent the connections between two neighboring pixels. The original image, which you can see in the left figure, was first smoothed using a Gaussian filter. Second, the vertical first-order gradient image was obtained, which you can see in the middle figure. Next, weights were assigned to all edges, and the highest vertical gradients received the lowest weights. Finally, paths were selected based on minimal cost, which you can see in the right figure. The path corresponding to the boundary surface between the tissue and the transducer was selected in the first 20 pixel rows. This is shown in the blue line. Beneath this path, the 3 best paths with lowest cost were selected, since the first best path did not always correspond to the correct fat muscle tissue boundary. These 3 paths are shown in red, where in this example the correct boundary was the second path found. 6 features were extracted from the selected paths. For all 3 paths, the depth and the local vertical gradient were extracted. This figure shows the mean DRS spectra for different groups of top layer thicknesses, with the 3 outlined regions showing the locations where the peak-based features were extracted. Both figures show changes in the DRS spectra for different top layer thicknesses. The left figure shows the situation for fat on top of muscle tissue. You can see that the larger the fat layer thickness, the deeper the fat absorption dips around 935 and 1200 nanometer become, and the flatter the water absorption area around 985 nanometers. For a top layer of muscle in the right image, it's exactly the opposite. The larger the muscle layer thickness, the smaller the fat absorption dips become, and the larger the water absorption dip. To predict the thickness of the top layer, a regression analysis was performed using the previously extracted features from both the DRS spectra and the ultrasound images. A linear support vector machine model was used with a tenfold cross-validation. For a top layer of fat, the layer thickness would be predicted with a mean error of 0.75 mm using the peak-based DRS features and 0.72 mm using the wavelet-based DRS features. For a top layer of muscle, we could predict the layer thickness with a mean error of 0.60 mm using the peak-based features and 0.48 mm using the wavelet-based features. After that, the classification analysis was performed to predict the tissue types of the first and second tissue layers. A quadratic support vector machine model was used with again a tenfold cross-validation. Both layers were classified independently of each other and using the DRS features only. This table shows the classification results for both tissue layers and feature extraction methods. The tissue type of the first layer was classified with an accuracy of 0.95 for both feature extraction methods, while the tissue type of the second layer was classified with an accuracy of 0.95 using the peak-based features and 0.99 using the wavelet-based features. Let's discuss the results. We were able to predict the top layer thickness of multi-layer tissue structures with an accuracy of 0.48 to 0.75 mm. These values are promising since they are in the same order of magnitude as the ultrasound resolution that was used as ground truth for the thickness. Also, the errors are smaller than the resection margin of a few millimeters that's generally used during oncological surgery. We saw that the algorithm performed slightly better for a top layer of muscle than for a top layer of fat. One of the reasons for this could be that the boundary between the first and second layer was more clear on the ultrasound images with a top layer of muscle. And as a result, the selected paths for a top layer of muscle might have been more accurate. When comparing the two different feature extraction methods we used in this study, the mean prediction errors using the wavelet-based method are slightly smaller than using the peak-based method. However, the question is whether these differences will be clinically relevant in the end. Previous studies in literature focus primarily on identifying tissue directly at the surface. In this study, good classification accuracies were achieved for both the first and second tissue layers. Again, the wavelet-based features performed slightly better than the peak-based features for classifying the second layer. The main differences between the methods is that the peak-based method focuses on specific regions in the spectra, while the wavelet transform takes the entire spectrum into account. This may explain why the wavelet transform method performs better in certain situations. So the results are promising. However, it still concerns a simple feasibility study using animal tissue with two types of tissue. In clinical practice, more tissue types will be encountered and tumor tissue has to be distinguished from multiple types of healthy tissue. A next step would therefore be to continue with an ex vivo study and test the performance of the algorithms in more complex situations with human tissue. We already started with that and are currently performing an ex vivo study using surgical specimens from patients with colorectal cancer. The same concept as used in the animal tissue study is used here as well. This means that we are acquiring both DRS and ultrasound measurements at multiple locations on the tissue. In the top left image, you can see an example of an ultrasound image. The top represents the measurement surface. The lighter areas at the top are fat tissue, and the darker area in the middle includes tumor tissue. At the bottom, you can see 3 DRS measurements that were acquired on the location of this ultrasound image. By correlating the measurement locations with the pathological tissue slices, we know the tissue types which were present. These can finally be used as labels for our machine learning algorithms. All 60 patients have now been included for the study, and the preliminary results look promising, but the data analysis is still ongoing. In conclusion, we proposed a new multimodal approach for multi-layer tissue assessment. The combination of DRS and ultrasound imaging resulted in accurate layer thickness predictions and good tissue classification accuracies. This shows its potential as a margin assessment tool during oncological surgery. Thank you for listening to my talk, and I would also like to thank some people that helped us during this project. If you have any questions or would like to know more about our research, please contact me and I'm happy to answer them.